This week on the Back Table Podcast.
I always tell the patient, something's got to give. So what's going to give in this case? Are we going to prioritize the treatment or are we going to prioritize the tissue acquisition? It's usually prioritizing the treatment.
Yeah, and I think the literature and operators do things a lot, everyone's very creative in what they come up with. Some people put the biopsy needle perpendicular to the ablation zone so that the probe doesn't get kind of in the way by coming alongside of it. People sometimes back off the applicator for the ablation and then move it forward once they've obtained the samples. But even you can either do it, sequentially, simultaneously. It's been shown to be obviously safe and efficacious. But, there's a paper out of France many years ago where they actually biopsy the lesion afterwards, right? Because they just want to get a histopathologic confirmation, right? So
and that worked.
Yeah,
70,
and
80%
because
of the time, something like that,
the ablation, leaves these ghost cells.
I want to switch gears a little bit. Minus Alan, we all do biopsies at this table. Well, actually, I don't know. Maybe you do biopsies.
I don't do lung biopsies.
Oh, okay.
But I do prostate biopsies.
Okay, good point. Very good point.
All right.
Very good point. How are you all deciding bronchoscopic versus percutaneous biopsy?
I think a lot of it just depends on who the patient sees first.
Sure.
And then there's clearly ones where that should go to the other team, and then we refer accordingly.
What are those examples?
So obviously the ones with adenopathy.
Yeah.
Right. I think that's everyone can agree.
It should go to EBUS.
Yeah. Anyone that needs EBUS should get a bronchoscopic approach, I think. And I think the other cases, it's evolving. And this is another situation. I think it's largely dependent on local expertise more than anything else. Because these guys are great. They can biopsy anything. Not every medical center has a Scott G and a Rob S. Or a Covey for that matter.
I don't have a Scott G or a Rob S either, right, in my institution.
So I think depending on what's locally available, probably drives a lot of what kind of biopsies that get done. I think you guys are probably very familiar with the recent Veritas study that was published. That was the study out of Vandy looking at manual EMN-based bronchoscopy with tomosynthesis guidance integrated into it versus TTNA for nodule biopsies. And the results were not inferior, right? With a little bit of a better safety profile for bronchoscopy, but with a downside of needing general anesthesia versus local. So those are the factors from there. There has been no head-to-head comparison of robotic bronchoscopy versus CT-guided biopsy. That study, I'm sure, is going to be done eventually, but it's not been done yet. But I think, like with any of these, it depends on who's doing the procedure at which institution. So I think that drives more the decision than anything else.
Is there a difference in the amount of tissue collected between the two procedures?
Again, I think that's also institution dependent. We have data now for robotic bronchoscopy biopsy sent for next-gen sequencing. Adequacy for next-gen sequencing is somewhere between 90 and 95%. So it's pretty good. And I think a lot of it is more dependent on the lesion type than the biopsy, meaning you have a subsolid lipidic cancer, you can biopsy away. There's just not that many cancer cells to get, right? I think that, to me, has driven a lot of whether or not there's enough. And then there's those squames with a lot of necrosis. You biopsy the heck out of it, and like 90% of what you get is necrotic and not viable. Like those ones are often insufficient for molecular analysis. But we expect to get adequate tissue for molecular analysis pretty much every biopsy.
What about for is there a substantial difference between cryobiopsies now and non-cryobiopsies?
Yeah, so we published a paper where it might have been the first on combining robotic and cryo, and cryobiopsies provide higher quality, more preservation of tissue structure, and more tissue in general, with a higher diagnostic yield than non-cryobiopsy approaches.
And then could IR do a cryobiopsy? Could you, if you had a needle gauge, could you put the probe in, do the cryo, and then use a biopsy needle and suck out some of the material, similar to what you would do?
Do they need to?
Yeah, that's true.
what I would
That's
ask.
true. Yeah, makes sense.
Yeah, I mean, we actually, interestingly enough, it's not a cryobiopsy, but we have used cryo to fix mobile tumors in order to perform a standard biopsy, such as very famously amongst the two of us, a small nodule that was presumed to be a metastasis from, I believe, HCC in the low anterior mediastinum adjacent to the heart that just turned out to be like a solitary fibrous tumor.
Yeah, no, I think hypermobile lymph nodes in the mediastinum are hard to biopsy percutaneously, just because they're always moving and you're never really sure you're throwing into them.
Well, and we're in an era where we're increasingly aggressive with percutaneous biopsies, right? And there's fully a gray zone, right? I think your point is very valid that it's local expertise that will delineate who's going to do the biopsy. But do you have a minimum size cutoff?
No, it kind of, again, depends on where that nodule's located, kind of the status of the patient. If they can do adequate breath holds and pretty consistently. I mean, we can go down to 4 millimeters, sometimes even 3 millimeters, but those are kind of unusual.
Yeah.
I mean, we wouldn't always be able to get to those things like in certain parts of the lower lobe.
Sure.
But up in the apex, sure.
Yeah.
We can go down. But typically, the threshold is very different across the spectrum. I mean, if you go out to some places, maybe the threshold is like 2 centimeters.
Yeah, sure.
I'm not going to biopsy anything smaller than 2 centimeters, right? Which seems like, oh, well, that's pretty big, but that's not uncommon.
I'm also perfectly willing, obviously depending on the size of the lesion, I will get 5, 6, 7 samples, and I don't think twice about it if it's needed, right? I mean, you don't have to, but if there's any concern, I feel like there's necrotic tissue on the imaging study, I want to make sure that I try to get a diagnosis. I don't see harm in getting extra samples either. So yeah,
I routinely, in every dictation I provide, it's 7 samples.
Really? Okay.
Yeah, every dictation.
Man after my own heart. I like that.
Yeah, lucky 7.
Yeah. Well, I think as tissue procurers, we have to get enough tissue to do what we set out to do. And there was a paper by Licht in 2020 where only about 20% of the biopsies that they did could actually meet all the molecular qualifications. So that's a fraction. Like, it wasn't so bad for EGFR, ALK, if that was the single or couple mutations. But if they wanted to do everything that they wanted, they could only do it in about 20% of the patients. So,
and I think it's also important to recognize there's getting enough tissue to send for next-gen sequencing, and the number of cells you need is variable depending on which commercial platform that you're using. But there is now technology that has been developed that you need about 1/10 of what you previously needed for next-gen sequencing, which means that pretty much every biopsy will be sufficient. So not only are we getting more tissue, but the amount of tissue that's being needed to run all the assays for NGS is also getting smaller. So I think the two kind of meeting will pretty much guarantee eventually that in the next, as soon as that becomes commercially available, will be pretty easy to provide sufficient material for NGS. I think one other situation where I think bronchoscopic approach may make sense is multiple nodule biopsies, because we looked at our numbers at about 10 to 15% of our cases, our lung biopsies are multiple nodules. And I think the threshold to do multiple nodules is even higher across in general, right?
And you'll do contralateral lungs, right? And we generally, I never do. I don't know. I assume you guys are the same. So great point. How about biopsy plus ablation? Same session, different sessions? I know where I stand. I'm curious where the two of you stand. And we've actually had this conversation before. So yeah.
Again, it's, I sort of base my decision on the size of the lesion and the type of the lesion. So if it's small, and I'll say roughly about 1.5 to 2 centimeters or smaller, and texture, kind of composition, if it's ground glass or part solid, I almost will always separate out the biopsy. Now, you can do a lot of things where you simultaneously put the probe in place, but I just kind of find that I just want to get the sample, a nice sample, and limit the hemorrhage so that it doesn't prevent me from seeing what margins I need to treat. Now, some people say, well, probe's in place, I can just ablate, whatever. That's fine, but I just don't feel comfortable. The other thing is when I separate out that biopsy from the ablation in those situations at about a week or so, I get full confirmation of what that tissue is, right? So it's not like the cytopathologist saying, well, it looks atypical, right? And there's no equivocation at that point. And I also get a window, kind of an opportunity to see how that patient behaves. Can they tolerate a procedure like a biopsy? Because if they're fine, then I know that ablation is going to go really well, right? Now, if they're squirmy or they're very uncomfortable, then I know I have to sedate them more or work fast during when they come for the ablation.
I really thought you were going to say general anesthesia. I'm a little disappointed, but that's okay. What about you, Scott?
Yeah, my decision is typically based, like Rob, on how important it is that we get an adequate tissue sample. For a de novo diagnosis, it's essential. So I'm going to separate those two cases. If the patient has known lung cancer, this looks like a metachronous primary, the patient's not going to go to surgery or get radiation, I have no problem in doing a simultaneous ablation and biopsy. I don't even have a cytologist come. In general, I don't really rely on them to drive my decisions because I'm biopsying small nodules. And so I'm going to be either in the nodule or I'm not, no matter what he or she says. And I typically, but not always, will favor doing a cryoablation in those cases because I can stick the probe once it's in place and then slide along its side of an ablation, a coaxial needle to perform the biopsy. And so that's typically what I do. And then you're ensuring that your probe's not moving, that you're going to complete the ablation. I always tell the patient, something's got to give. So what's going to give in this case? Are we going to prioritize the treatment or are we going to prioritize the tissue acquisition? It's usually prioritizing the treatment.
Yeah, and I think the literature and operators do things a lot, everyone's very creative in what they come up with. Some people put the biopsy needle perpendicular to the ablation zone so that the probe doesn't get kind of in the way by coming alongside of it. People sometimes back off the applicator for the ablation and then move it forward once they've obtained the samples. But even you can either do it, sequentially, simultaneously. It's been shown to be obviously safe and efficacious. But, there's a paper out of France many years ago where they actually biopsy the lesion afterwards, right? Because they just want to get a histopathologic confirmation, right? So
and that worked.
Yeah,
70,
and
80%
because
of the time, something like
the
that.
ablation, leaves these ghost cells, right? When you do heat based, so you just basically take some samples afterwards. And there's a paper recently out of China where they actually did then they did an ablation, and then they did post biopsies all in the same session, and that way they can confirm that things maybe look dead. I don't know, right? But wanted more information out of that ablation zone.
So when you guys know, both for SBRT and ablation, that they're not going to get surgery, and the only chance for invasive mediastinal staging is a bronch and EBUS, how do you pick and choose which patients you want to get a EBUS on before you ablate? And this is obviously not the radiographically positive mediastinum, because everyone agrees. It's the CT scan looks okay, or PET CT looks okay. If it's a 2 centimeter relatively central one, the pretest probability of a cold mediastinum is higher.
It's high.
So at what point do you say, all right, I want to get mediastinal staging before, or you say, you know what, it's not that important in the patient population we're ablating, and as long as we confirm that nodule is cancer, I'm okay not getting invasive staging.
I think it's like a sliding scale, it's partially gestalt, right? If the patients are otherwise very healthy and very motivated and they're refusing surgery, let's say, right? I'll probably get them a mediastinal and send them for an EBUS. Even if it's a smaller peripheral lesion, I might still send them for one. As it gets bigger and closer to the mediastinum or central structures, that increases my pretest probability of mediastinal involvement. And so then I would want to send them for an EBUS. I don't know if I have like a strict cutoff of size or age or distance, but it's something that I think about a lot and talk to the patient about. And usually these patients have seen many other physicians already. So a lot of the patients have sort of an idea of what they want, right? So it's sort of meeting in the middle with the patient. And
I totally, I'm kind of the same way. Yeah. Like there are cases where the tumor looks big, even if it's peripheral, 3 centimeter. Yeah, even though maybe PET scan's not, or CT scan's not positive, those guys may benefit, right? So, and then like most patients, they kind of have
An idea what?
an idea. And sometimes maybe they're really, maybe advanced age and they don't want to, have another procedure. So they'll just do the ablation or whatever. And I'm good with it, whatever.
Happens.
Yeah, happens.
Yeah.
Yeah, for sure. I do want to mention actually the one advantage about working so closely with IR, for me at least, is that I can just call one of them up and say, it's really important that we get lots of extra tissue for this one, because we're thinking, like, for example, if it's a radiation suspected recurrence and you're trying to biopsy the center of an FDG target, right? I mean, I would like to be sure that there is or isn't cancer in this target, So being able to have that conversation, I think is really vital, because sometimes patients come from the outside community and I just wish I could get a hold of the physician. It's very difficult sometimes to get a hold of them. Yep. So, yeah.
Real quick, imaging algorithm, post-local regional therapy. What do you do?
I get a chest x-ray about a week after the local therapy just to make sure that the patient doesn't have a pneumothorax. Quick check-in with my nurse practitioner to make sure they're doing fine. Then I get a month non-contrast CT. This is for non-small cell lung cancer. And then I basically go every 3 months with ideally a contrast-enhanced CT, renal function permitting, allergy permitting, and often a PET CT on the annual basis. And that, Now that is for year 1. Year 2, what I do is I space the scans to every 4 months, and then year 3 every 6 months.
We struggled a lot in kind of the trials that we ran and about how do you use RECIST criteria on something that you're artificially making bigger than the tumor, right? And so I think what we've been doing in most cases is that 1 month scan. Now, again, it doesn't have to be exactly at 1 month. It can be at 3 weeks or 5 weeks, 6 weeks. But what you want is a representation of what that ablation zone looks like, because we know the natural decay and involution of that ablation zone over time, right? So that 1 month scan is our new baseline, and from which we would expect things to involute and stabilize. And if we see anything sort of go off that direction, then we know that we might be dealing with a incomplete ablation. And so right now, I think we have so much data on this that it's not so much of a mystery, what is a tumor progression or incomplete ablation. So I kind of do what Scott, so we could do the 1 month, and then I do 3 to 4 months in the first year, then 4 to 6 months in the second year. Now, if it's for metastatic disease, it's a little different because you might have multiple nodules to treat. And you get a window of opportunity to look each time they come for another ablation, right? So maybe I'll get the 1 month after the last series. And depending, I usually let the oncologist dictate what the schedule is, because some active or relatively active patients may be getting their scans every 3 to 4 months. So I just hop on that schedule.
When would you get the first PET scan? Or do you bother? Just let the oncologist grab that?
I think if it's a primary lung cancer, I probably do one maybe annually. For metastatic disease or oligometastatic disease, I kind of, again, let the oncologist sort of drive that.
Okay. Yeah, typically we would do a scan every 3 to 6 months for the first 3 to 5 years, and then annually after for early stage lung cancer. I only get a PET scan if I suspect recurrence. And suspicion of recurrence is, dealer's choice, right? If it grows a certain direction, a certain size, and a certain shape, then that would prompt me to get sooner scans. But I usually see them for a first follow-up at 1 month, schedule the CT scan 2 months after that. That's their first scan. I've gone back and forth about when to get that first scan, because if they get 3 fraction lung SBRT or 1 fraction lung SBRT, the pneumonitis hasn't even started to develop yet. So then I'm caught in this weird situation where I'm like, well, do I really care that I can see that? Does it really matter? But I guess it makes me feel, better to see it. So if they get 5 fraction, usually that means that they were treated an extra few days or maybe a week. And for some reason, the scans will usually end up showing that pneumonitis on that first 3-month scan. And then after that, if it looks fine, I usually move to 6 months. If it looks suspicious or the lesion's growing a certain direction, then I might get it in 3 or 4 or even less, depending on the situation.
Yeah, very similar. I think a lot of it depends on, is it primary lung? Is it metastatic? What is the anticipated growth rate of the underlying tumor? For a ground glass lesion that was barely growing to begin with.
Totally different, yeah.
Right? So I think it really, like, guidelines are guidelines and kind of frameworks are frameworks, and then you kind of adjust it and tweak it to the lesion that you treated.
Yep, good point. I think I do a little bit more contrast enhanced CT. I think I get my PET a little bit earlier, usually in the 6-month range, something like that. But and I think great place. You were saying something.
No, we used to get PETs. We used to try to get PET scans as the first scan after radiation.
Oh yeah.
And then insurance companies started to push against it.
Yeah.
And then the guidelines, NCCN guidelines changed to say that that wasn't, recommended anymore. So insurance companies even pushed harder against it. So instead of having to just have that conversation every single time with the peer review, physician, I just stopped doing it, and so far it seems to be okay. Yeah, but for recurrences or suspected recurrences, we'll do the PET, and probably I've done maybe like, let's say 10 PET scans for suspected recurrences due to the lesion growing in a certain way, and out of those 10, maybe 5 have had focal FDG uptake. And out of those, or 6 maybe, out of those 6 that had focal FDG uptake that had great biopsies done, I think 1 or 2 of them turned out to have cancer in the biopsy.
Yeah. And the PET's helpful, I think, just to guide the biopsy, if nothing else, right? So 100%. I know we have a couple of extra cases. Scott had a case and Alan had a case.
I guess we can talk about it. You just popped it up.
Yeah, there's only a few slides for both. So
it's an interesting one. I felt like it was way at the costophrenic angle, super deep. I think that's a video on the right. That's the intraoperative cone beam CT that's integrated. And you can see the end of the catheter, and there's the needle. And then that's the needle going into the lesion. And
done.
And then go to the next window, next slide, and you can see that's the...
that looks like Scott G's off-axial.
Yeah. You stole my images there, Scott.
I thought that was your case at first.
Yeah, this is just to highlight, like, basically with the current technologies with robotic and integrated cone beam CT has been like a game changer. And it's like, no wonder you guys do so well, because you see your needle inside the target. You got it, right? So we didn't do that for the longest time, right? So now we do that, and we find, oh wow, that really works.
This gives me so much hope, Scott. This gives me so much hope that I will have fewer lung biopsies to perform.
And then you can go to I think the next slide is one that's interesting from a treatment perspective.
I will say I'm not as good as Rob at remembering who published what paper, but there is a paper to that point, right? There are people that will pull the patient out of the gantry and then fire the device and then send the sample off. But there is data that shows that if you document the trocar through the lesion, then obviously you're more likely to get tissue positive tissue, right? So it inherently makes complete sense.
Right.
Yeah, and just having cytopathology or ROSE has certainly improved diagnostic yield tremendously, right?
Yeah.
So this is an interesting case. So this patient has this ground glass lesion right on that fissure in the left lower lobe. And it grew a little bit over the course of a year. She is 71, very healthy, never smoker. So now we know it was there a year ago. It's probably a little bit more, it's convincingly a little bit bigger, and not just, technique difference and breadth or whatever. It does seem a little bit bigger. What do you do for this one? Like, do you do anything, or do you keep watching it?
I don't love this nodule. Mm-hmm. It's not just that it got bigger, but when I'm looking at the edge of this, it's a little spiculated, in my opinion. It's just right on the edge. It looks like there's a little architectural distortion, and so it's something that I think I would want to biopsy.
Would you classify this as a pure GGO?
I'd like to see additional imaging.
They all they just assume they all look like this, and there's clearly nothing obvious. I didn't take a video.
I think there is a semi-solid, not a true solid component, but it is a little denser around the edges.
You can see along the fissure, there's a little thickening right at the fissure.
So, I think we all suspect it's something in the adeno spectrum. It's a question of, like, is it in situ? Is it adenomatous hyperplasia? Is there an invasive component or not? And that's the never-ending question, I feel like, with these.
I don't think it would be wrong to wait at least one cycle. I know it's been waited. You waited once, but you said as the growth is maybe equivocal, right? I don't think it would be wrong to continue to watch.
How long? How long would you watch? Wait.
6 months to a year.
Okay.
I guess the question always comes down to is what's going to be least traumatizing to the patient? Yeah. Is it less traumatizing to wait and then have a biopsy in 6 to 12 months or 2 years from now? Or is it less traumatizing to answer questions?
Yeah. Well, some people just can't wait, right? And so they want something done today. And so well, then we just take them from the scanner to the other scanner.
Yeah.
So you can go to the next slide. Oh, so that's it. It's
wow. Nicely done.
I miss working with you.
Avoided the fissure, right?
The ion robot, though, right? Okay.
This is avoiding the fissure, right? And that's the cryoprobe. So I just placed it just proximal to that fissure so I don't give her a pneumo. It's consistent with lipidic adenocea is the final path report. So knowing that now, it doesn't say if it's invasive or not, just says consistent with. So we don't know it's actually invasive. It's obviously less than 3 centimeters. Do you offer treatment, or is this another one of those like co-decision making kind of? Because she didn't.
How old was the patient?
71, very healthy, otherwise healthy, has a little bit of hypertension, maybe really just white coat hypertension and not real hypertension kind of, but otherwise completely healthy.
I mean, I think you've gone so far as to make a diagnosis. So at this point, the hand has been dealt.
Yeah.
The question is just which way one would go about treating this. And I think that the reality is that no matter how this is treated, she's going to get an excellent outcome.
Yeah. So that's the next question, right? So we had this long conversation, like this is probably going to show some sort of cancer or something in the cancer spectrum. Now, knowing that, would you want treatment? And she's like, well, I don't know. What's the treatment options? So we go through the whole rigmarole of all the different treatment options. And then she's like, well, maybe, maybe not. Well, do you want a biopsy? I don't know. And this is back and forth. Finally, she obviously decided to get the biopsy done. And she gets the answer. So now, this is a question of maybe you really didn't even need to biopsy in the first place.
Sure. It's too
now
late
we
now.
have the answer.
Too late now.
Now you're like, what treatment do I offer?
And you
right?
staged her too, I presume.
Staged her and the mediastinum is clean.
Yeah.
Proton therapy.
So that's the question. Like, to me, the most important thing in my mind is first do no harm for her.
Yeah,
right? That's
very
to
valid.
me the number one priority, because I'm not even sure that she needs any treatment, right? So I want to make sure that absolutely, if she wants treatment, whatever we offer has like as close to 0 side effects as possible. So what is that in your guys' opinion? What is it? PEF? Is it microwave? Is it surgery? Is it SBRT? Like, what is the safest, least?
Well, I'll say it's not PEF. So only because with PEF, because it can only afford currently 1 centimeter ablation zone, you're not going to provide margins on this thing, right? So really the goal with PEF is you can use it around critical structures, maybe to be adjunctive to whatever ablation you're going to do for the larger part of the tumor, or you're hoping for some sort of immune stimulation or modulation, right? So I think, with that being said, PEF's definitely out for this, I think if you look at the papers of sort of natural history of lung cancers, those, again, this is a very early one, and we don't know if it's minimally invasive versus truly invasive. But if you truly have like a real lung cancer, doing nothing, most of those papers show that you will have problems with that cancer, right? Mortality, about a little over half of these patients will die from their cancer as opposed to just doing nothing, okay? So I think you've already proven that it's a lung cancer. Now, where it is in the spectrum, we don't know. I think it's probably worth treating. Now, do you have to treat it today versus like a month from now? I don't think that necessarily matters, but you have to deal with it at some point. And even papers in surgical series have shown that if you wait even 30, 60 days, from the staging to that tumor progresses, to something more advanced. And so I think you have to act on this in some sort of fashion. Like I said, it doesn't have to be next week, but it needs to be dealt with in the near future.
Now that it's biopsied.
Yeah.
Had it not been biopsied,
Then, because you don't know, right? So you're watching it.
Yeah, it's
right?
hard. That's
now,
hard.
you can run it through a probability calculator and all these kind of things, but you're still,
I think for a lesion like this, what's most important is for this patient to hear out the surgeon, the radiation oncologist, and the interventional radiologist as to what their treatment options entail. Because I could get in a debate on the side of any of those treatments and explain why it would be the most effective with the least side effects and the least adverse outcomes over time. And I just think that for something like this, it really comes down to what the patient wants. We don't have a lot of data to say one is better, is superior to the other as far as the therapeutic options. But I think that we could all agree the results are going to be excellent. This patient will be cured and there will be no recurrence with all likelihood.
And for the sake of discussion, let's say there's recurrence post-ablation. Any concerns with SBRT post-ablation and vice versa? We talked a little bit about microwave post-SBRT. Any concerns with cryo post-SBRT?
Well, for SBRT after ablation, it depends on where the tumor has recurred.
Sure.
If it's a very small recurrence that's very obviously localizable on CT, then it's very easy for us to hit. I haven't seen that many recurrences after ablation, but sometimes it recurs in like a scar area, of the ablation zone, in which case it can be difficult to figure out where exactly I'm trying to treat sometimes.
Yeah.
So that can be difficult, but for the most part, it's not a big deal to have to treat with radiation after.
No concerns with cryo post-SBRT?
There's not huge concerns, but I would just say that with this caveat is if we're doing cryo or any of the ablations in the early term following the SBRT, say within the first year or 15 months, because that tissue is actively inflamed and organizing, there's a higher rate of complications, including bleeding that would not occur under normal circumstances. So you just have to be a little more cautious.
Yeah, I would even say that once, you had even true radiation fibrosis, we talked about the ventilation perfusion differences and soft tissue conducting more heat-based energies than you realize. But the other thing is because of the bronchiectasis and sort of the fibrosis around the arteries, making them less compliant, you have to be a little careful in how you place these large probes. So cryo or microwave, whatever you decide. Because if you just indiscriminately ram that probe across ectatic airways and blood vessels and arteries, you're getting a bleeding that's uncontrollable because it's just, there's no resilience of that tissue.
Yeah, great point. So there is the option of doing brachytherapy for recurrence as well. Okay. So we have some patients that come, like I said, I have less than a handful of patients, but I do remember a few patients from outside that had the recurrence, and then we ended up treating with HDR brachytherapy just to the FDG active area, right? Because the scar is huge. It was biopsy proven to be positive. We did HDR brachytherapy as salvage. You can give a huge dose because it's just all scar right in the middle of that. Done that before, and that seems to be a pretty good salvage option for radio recurrences too.
Great point. For your case, what did you do?
The patient decided they wanted to wait.
Okay.
So we went, after all of that, they were like, let me think about it.
Yeah.
And this result, I just had the discussion with her, a couple of weeks ago, and now she's going to get a follow-up scan in 3 months to make sure it didn't, because I knew it grew over that year. I don't know if it grew over the last month of that year or slowly over the course of that year, right?
Sure. Yeah.
So I don't know. So I said, let's do a short-term interval scan in 3 months just to make sure it's not growing quickly, which would then obviously prompt a more urgent treatment plan. A few other questions I want to ask.
Yeah.
Does the fact that it being on the fissure change the risk profile of the chest wall for percutaneous ablation or SBRT?
Not for us.
Not really. There are times for a nodule, let's say a lesion that was a little bigger than this, that was on the fissure, where we may opt to actually place an ablation probe in the other lobe so that we can adequately freeze that margin.
Does that fissure act as an insulator?
No.
So most of the time when we're close to the fissure, you'll see heat cross it, you'll see ice cross it. I think the thing you have to be careful of, so everybody talks about the more pleural surfaces you cross, the sort of a linear relationship between that and pneumothorax, right? So 3 pleural surfaces, if you went through and through from outside, would be like 90% chance you're going to get a pneumothorax. But who really cares about that? But what sometimes happens is if you, again, cross the fissure and let's say you freeze across it and that thaws and starts bleeding, then it goes immediately into the pleural space.
No tapping out.
Right. And so you've got to be a little careful about just saying, well, I'm going to put the needle across, bleeds, and then now you got no way to really stop it. It's different if you freeze over the fissure without the needle crossing.
I see. So you would maybe plan the trajectory of the needle accordingly.
Yes, or sometimes you can go through, even if you're coming perpendicular fissure, maybe you just kind of slowly push that lung so that it's just stretching and not actually piercing and just going all the way across that fissure.
Got it. Anecdotally, do you feel like cryocautery helps with that phenomenon?
Yeah, there's a situation where I might start doing a cautery maybe at the fissure and then back up and then do the on the way out but I don't, so as opposed to just doing it on the very outer periphery of the lung. And
Now, I would just say that for this nodule, the approach for an ablation would not be directed in my hands toward that fissure. I would come in a sagittal plane, and this will just skirt along the fissure, parallel to the fissure, and it's just another tangential plane toward the fissure.
Absolutely. That being said, I mean, both of your pneumothorax rates are very low. I think probably lower than most of what I've seen around the country, including lower than mine. I will say, though, some of the lesions that I treat, I get a lot of metastatic disease in complicated positions that require some complex trajectories. But if I had to go through the fissure, I don't know that I would hesitate. I'd just drop a tube and, I'm just trying to ensure that I'm not getting a bronchopleural fistula, which, but if I had to, I would go through the fissure.
It's made to be crossed.
Yeah.
The thing about pneumothorax is I think that in our practice, we found a couple things to be super helpful. One is that we feel comfortable in managing patients at home with a Heimlich valve most of the time. Not all the time. They're older, they're frail, they have mobility issues. Of course, we're going to keep them in the hospital. The second thing is that if you've managed a patient with a chest tube for 24 hours and there's a persistent air leak that seems fairly vigorous, the likelihood of that persisting for multiple days, if not longer, is very high. So in our practice, we've gone to very early sealing of that pleural hole, usually by large volume blood patch and sometimes assisted by surgical adhesives such as co-seal.
How do you target?
So if we are thinking about applying a surgical adhesive, what we will typically do is get a CT scan and see if we can actually see the hole. Get very thin cuts. Sometimes we can actually see the hole, including the first case that we ever did. And then we just put a 19 gauge coaxial needle right on that hole and apply the adhesive, and then typically follow it with some blood.
Sure.
So that you kind of smash it in there. When we do a blood patch alone, which is typically what I do these days, I typically will administer about 160 cc's of autologous blood into the pleural space. Typically, I'll have an inlet tube, which is right near where I think the hole is, and an outlet tube, which is fairly sizable, maybe like 18 French, that's on the opposite side of the lung, and I'll suck up the lung. So oppose the visceral and parietal pleura while administering the blood patch. So it just forms like a sealant or stickum along the outside of the pleural surface. I'll keep the outlet chest tube on maybe negative 15 or 20 wall suction overnight before clamping them in the morning and begin the process of discontinuing. And that is effective, not all of the time, but the vast majority of the time.
Yeah, and then, again, if you can see the hole, you can puncture that hole, or puncture the cavity and put the surgical sealant inside of there or glue or whatever you want, right? Especially if you see a subtending bronchus going into a cavity and then a hole into the pleura, you just go ahead, put the needle in the cavity, fill it up, and then you can plug the needle tract with BioSentry or something else so you don't further complicate the issue. But if you're going to do a autologous pleural blood patch, as Scott, I think it's best to have some sort of egress and an ingress catheter because you got to keep that lung up when you put the stuff in.
Yeah, sure. Yeah. Also, how did you get to 160 cc's? That seems like an oddly specific number.
It's the number.
It's the number.
It's the magic number.
Enough said.
Some of the techniques that I don't want to derail, but when we know where the leak is, or I do a very high risk pleural-based biopsy, or I know that the needle went through the visceral pleura. I'll inject autologous blood through the catheter.
Yeah, sure.
Because it's going to go exactly where the biopsy was, right?
Yeah,
So
absolutely.
that's another way to potentially, because if you know,
How much do you inject there?
160 cc's.
10 cc's. I only put in 10 cc's, very little. Yeah.
Too little.
Yeah, I know. Maybe I need to go big or go home, huh?
That's right.
Yeah.
Very cool. Anything else on this case?
No, that was it.
Alan, you want to do your case?
It should be quick. Yeah.
Okay, let's
Yeah.
do it.
So this is a pretty young 56-year-old male. He had a pretty small ground glass nodule. It was suspicious. You can barely, it's in that bottom right, lower
Yeah, for
lobe,
sure.
right? It's very faint. And this is what his PET scan showed. So negative in the mediastinum. I'm showing it again here just because like you can tell that it's really kind of hard to see, and it's actually filled with air in the middle of it, right? So it's a cystic structure. So this is actually a lesion that would be kind of hard to see on a cone beam CT. And so if you go to the next slide, I was just showing like how it looks, right? It's like kind of difficult to see. And then, so I had interventional pulmonology try to do a biopsy of it. He did a cryobiopsy, and then he placed the fiducial marker at the same time. Notice that the comment mentions that it's very hard, it's very scant and pretty much non-diagnostic. So this patient, his backstory is that his wife actually passed away recently. He has a daughter that's, I think she was like 1 or 2. And it was during the summer, close to the summertime, or his daughter was like about to start school. So he wanted to get all of this done and not have to worry about it because he wanted to take care of his daughter. So we could have, sent him for a rebiopsy, percutaneous or something. But he really, really wanted treatment, and he really wanted no downtime. And so I ended up doing a radiation SBRT to this guy. You can kind of see the fiducial marker there. So the fiducial marker is probably maybe even bigger than the target itself. So I had to make a larger target volume. Also, you can see that the dose sort of forms this little diagonal structure, right? That's because as the patient's breathing, it did move. We do have techniques to limit dose when the patient's breathing. So we can do something called gating. So what happens is that these images are taken and they're binned. And let's say they're, breathing 0 to 100 in terms of inspiration. We can actually only turn the beam on when the patients are in different phases of inspiration or expiration. So we're only treating from like 30 to 70. And so then the patient, we can draw the target to be smaller. Usually we would do that if the tumor's moving more than like 2 centimeters, and then we can limit it and reduce it down to a smaller target volume. We also have a protocol open now where if it's a very obvious lesion that you can see clearly, you can put them on the MRI linear accelerator and actually deliver it in real time with a breath hold technique. This patient I didn't do any of that with because the tumor wasn't moving that much. And so I treated this on a regular linear accelerator. I did 30 gray in 1 fraction. So the patient only came to the hospital twice, and they can spend more time with their daughter.
That's awesome.
Nice, nicely done.
Great reason to be very aggressive, right?
Yeah.
Very, very, very nicely done. And I think it also highlights, all of you are very cordial and easy to talk to and easy to work with. This is the first time, well, not for you two, but this is the first time we're meeting, right? And I think when you're in the multidisciplinary setting, it is easy to let your ego get in the way and want to take care of the patient or yourself, right? And I think none of us really have an ego. It's really nice to see. I'm sure we all similarly feel the sentiment that we don't put down other services therapies in tumor board or in clinic, right? We offer what we have to offer, and if all else fails, that patient should see multiple of us, and then the patient can decide what they want, and that's perfectly acceptable, right? We have no ego in this. This is about the patient and what they need, right? So, well done. That's awesome.
Thanks, Alan.
All right, with
That's
that,
great.
let's wrap it. Thank you all. This was
Thank you.
fantastic.
Thank you so much for joining us on Backtable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtable onc. That's _backtable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Bagrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.